Okay, we're going to go ahead and get started. Thank you all for joining on this Friday afternoon. I'm Elizabeth Mills from Macmillan, and I know many of you have joined us on Monday and Wednesday as well. Thank you for joining us again today. We're excited to have Bob Julien with us as part 3 of the psychopharmacology update. I do want to discuss WebEx quickly in case you were not on the earlier sessions. You are on mute. If you have any questions throughout, feel free to chat them through WebEx, and we will answer them at the end. And if you're having trouble with your audio, the call-in number is here if you can see the screen, or if you have any difficulties throughout, you can call in there. In terms of the chat functionality that I was referring to, in order to chat a question, you just want to go to that menu bar at the top, type in chat, and then enter your question. And at the end, if you have a question, just go ahead and raise your hand and you will be taken off of mute, and we'll get the questions to Bob. And with that, I'm going to hand it over and get started.
Share my desktop. Good morning, at least it's morning out here in Portland. It may be early afternoon where you are. I noticed looking at the attendees list that my co-authors of our 40th anniversary edition are with us today, to Joe Camati and Claire Advocate. If you have joined yet, welcome. I don't know if you heard our first 2 lectures or not. I hope you can see my slide up here in the screen.
Go ahead and click on Share My Desktop one more time, Bob.
Okay. Let's see if I can figure out how to do that. Share my desktop.
There we go.
Are we on now? Okay.
Yep.
Well, welcome again as we celebrate 40 years of psychopharmacology education. And this is our 3rd of a series of 3 lectures that you can use or you can show to your students. The first was on antidepressants. The second was on anti-epileptic drugs, both their uses in bipolar as well as their off-label uses. And this lecture is on atypical antipsychotics. These are perhaps my favorite 3 lectures on psychotherapeutics because they all dovetail together. And I think you'll see this as we progress through this slide set. And today we're going to focus not so much on the use of antipsychotics to treat schizophrenia, but on uses outside of the treatment of schizophrenia. First question is, what is an atypical antipsychotic? Well, to answer that question, I have to first ask, what is a typical antipsychotic? Well, the typical antipsychotics were the so-called first-generation antipsychotics. Those drugs were dopamine 2 receptor blockers. They actually induced a clinical stage of Parkinsonism, which is associated with reduced dopamine levels in the brain. And the efficacy of those drugs closely paralleled the onset of extrapyramidal side effects, movements, motor slowing. And indeed, the correct dose of those drugs was basically as much motor slowing as the patient could tolerate, and that was as far as you could push the drug. And that was our first-generation antipsychotics. Students still need to know those drugs. They need to know the dopamine 2 receptor activities, some names of the drugs, and their use in treating schizophrenia. The use of those drugs was earth-shaking in that it basically emptied out many of the hospitals that were populated by schizophrenic patients. Well, when Clozaril and followed by many more of these drugs came out, these so-called new generation drugs. This is a slide from Carol Tominga, and it's as good a teaching slide as I've seen. When these new generation drugs came out, she correlated the dose of the drug with the efficacy either to reduce symptoms of schizophrenia or to cause extrapyramidal side effects. And this is the claim to fame, essential claim to fame of these drugs, that you could find a dose of drug that was sufficient to treat schizophrenia in the absence of extrapyramidal side effects. Same thing applies to treating bipolar. You can find doses that don't cause extrapyramidal side effects, but eventually you get there. For example, you may find a dose like Risperidone, 2 milligrams may have efficacy with little or no side effects. Somewhere around 4 milligrams you'd begin to see extrapyramidal side effects, even with more efficacy. It went up to about 8 milligrams a day. It became quite significant, and the drug indeed looked a lot like a first-generation agent. I'm not going to teach the mechanisms of action here, but they involve a ratio of dopamine 2 receptor blockade with serotonin 2 receptor blockade. That as a general rule, and there are some exceptions to that with some of these drugs, such as Aripiprazole or Abilify. But I think it's important to understand how these drugs differ from the traditional drugs, which were largely the phenothiazines, such as chlorpromazine and Haldol. So those drugs are unable to separate antipsychotic efficacy from Parkinson-like motor slowing. Important for students to understand these older drugs are still occasionally used, but they're the classics and they're the hallmark of antipsychotic drugs. Well, the so-called second generation of drugs included the early drugs, Clozaril, Risperidone, and Zyprexa. These were the first three drugs to really separate antipsychotic efficacy from extrapyramidal side effects. They had marked side effects. Number one, they could be associated with extreme weight gain and metabolic disturbances, including early onset of diabetes. And I'll show a slide on the weight gain in a little bit. Basically, this was due to a stimulation of feeding centers in the brain, and these people just feed as long as there's food available. Now, we have the so-called third-generation antipsychotic drugs, which are a continuation of the earlier ones, and these are namely Julien, Seroquel, and Abilify. These drugs have significantly less weight gain. In fact, when they first came out, people said no weight gain, but for those of you who do therapy, I'm sure you've seen patients that have gained weight with Seroquel and perhaps also with Abilify. These also have fewer metabolic problems, a lower onset of diabetes, although it's still a good idea to periodically test. Now, in addition, these newer drugs tend to be much more anxiolytic and also to have antidepressant effects. And indeed, this is one of the wide uses of these drugs are as anxiolytics and as antidepressants, which is a long ways from treating schizophrenia. So, and they also have far-reaching usefulness in other disorders, and we'll talk about those in this hour. They also may be less antipsychotic, and you tend not to see them as much in these drugs in treating schizophrenia. This was an interesting paper in Lancet a couple years ago, Cipriani's paper. Antipsychotic drugs are significantly more effective than mood stabilizers, and these are our drugs we talked about Wednesday, drugs like Lamictal and Depakote, valproic acid, for the treatment of acute manic episodes. An important point on these is several of these are available in parenteral form. I just saw a forensic case the other day where an horribly agitated patient in an ambulance being transported to the hospital was administered parenteral Geodon as a calming agent. In many cases, combination drugs may be necessary, and this involves the treatment of bipolar, or so-called challenging bipolar patients, that you may need a combination of Seroquel plus Lamictal in order to be effective. So here we're combining an atypical antipsychotic with a mood stabilizer. I gave the example of the other day of how there's an overlap in uses. Bipolar is one of the overlaps. Which one would you start with? Well, sometimes you may need one from each class. Lots of options in the treatment of bipolar depression. I introduced that a bit the other day, where patients with bipolar spend the majority of the time in the depressive phase rather than the manic phase. And indeed, treatment of bipolar depression has been a real challenge, mainly because the use of only an antidepressant drug may result in a manic flip. These drugs are not associated with manic flips. One of them is a combination of Zyprexa and Prozac, so-called Symbiax, Olanzapine and fluoxetine. It is effective. I'll mention, well, I really don't like this combination. Fluoxetine is fine. It's got a long half-life. The norfluoxetine has an even longer half-life. But the Zyprexa, I think, is somewhat antiquated as it's associated with the weight gain and the diabetes. I'd rather see a fluoxetine Abilify type combination than this one. Seroquel can be effective in the treatment of bipolar depression. That's the Quetiapine. Lamictal is used either as monotherapy or in combination with an atypical antipsychotic or indeed with lithium. The fourth FDA-approved one is Latuda. We'll cover that in a bit. In fact, as it's been out now a couple years, it's considered drug of choice for the treatment of bipolar depression. I do see Abilify and Ziprasidone have not been terribly effective, and I don't see them as monotherapy for bipolar depression. Potentially are the use of either Provigil or its derivative, its optical isomer. Those are potentially effective, but personally I haven't seen them used. Well, Lurasidone has just within the last year been FDA approved for monotherapy or in combination. There's two articles in last October's American Journal of Psychiatry by Lobel, L-O-E-B-E-L. To see the abstracts, go on pubmed.gov. Just type in Lurasidone and Lobel, and it'll bring up their abstracts. There's another paper last year, another Lobel paper looking at the efficacy of Lurasidone for relapse prevention in patients with schizophrenia. Now, where do you see off-label uses of these drugs, or the wide range of uses of these drugs? Here's a laundry list of them, and it's quite a list. Behavioral control in the elderly residing in care centers, especially the agitated elderly. There are drugs of choice in autism and other pervasive developmental disorders. Drugs of choice in bipolar disorder and bipolar depression. We've alluded to that. Since these drugs stimulate the feeding center, especially the drug Zyprexa, it can be used in patients who might want to gain weight in the treatment of anorexia. We discussed on Wednesday the use of Depakote in treating adolescent mania and behavioral discontrol. These same drugs are used for the same purpose, the atypical antipsychotics for adolescent behavioral discontrol disorders. And anytime you see disorders associated with behavioral aggression or agitation, these are probably the most effective drugs we have. We talked a bit about anticonvulsants in patients with borderline personality disorder, especially to control the anger and the rage. These drugs are quite useful and indeed are used perhaps more frequently than the anticonvulsants. We've already talked a bit about resistant or persistent depression. This would be unipolar depression, not bipolar depression. So patients with difficult to control unipolar depression a drug like Julien or Abilify can be tried. One disorder I don't read much about is dysthymia, persistent low-level depression. Drugs like Abilify or Julien can be quite effective. And in resistant or persistent anxiety disorders, drugs like Seroquel are particularly useful in persistent anxiety disorders, and I'll come back to that in a few minutes. Well, these are off-label uses. Here's a paper from JAMA a couple years ago, and it discussed the efficacy and safety in agitated dementia, resistant anxiety, OCD, eating disorders, PTSD, insomnia, personality disorders, depression, and substance abuse. So it's interesting to read, and I think if you're teaching about these drugs, instead of just talking about bipolar disorder, I personally feel that you need to address all these other disorders where atypical antipsychotics are being widely used for treatment. Now, there was a big controversy about 5 years ago. The FDA absolutely hated the off-label use of drugs like Seroquel in treated agitation in the elderly. And they said there's a 1.7 time increase in deaths associated with these drugs. These were due to heart failure or to infections. How these two relate, I have absolutely no idea. The FDA said this was a class effect and all of these drugs were black boxed. Well, after that was done, in August of 2005, when this controversy was just beginning to rage, the medical letter made this statement. Now, the medical letter comes out, it's either weekly or bi-weekly. No advertising in it. They don't behold to the drug industry. And it's really quite a decent journal to read. It's very short. It's about maybe 8 pages per issue. And they state that even though controlled trials proving efficacy in agitated, demented elderly, trials are lacking, the medical letter consultants found that these drugs, such as Risperidone and Zyprexa, to that I would add Seroquel, are beneficial in calming agitated or aggressive elderly. The FDA has found a slightly increased risk of mortality with such use, but there are no good alternatives. Those were my italics. I have to give a little story here. About the time this happened, my father, who was one of the last of the European World War II veterans, passed away. And in her dementia, my mother thought that he had run off with one of the caretakers in their assisted living home. She became an agitated, somewhat demented elderly. The lovely owners of this home said that they couldn't take care of her, so she'd have to go to an Alzheimer's unit. I tried to avoid that, and I suggested a trial of Seroquel. She responded beautifully. She calmed down. She was able to stay in the home. She appeared to be just a bit, let me use the word phenothiazinized, a little bit slowed down. She had some early Parkinsonism, and that seemed to get worse. Finally got down to a dose, I believe now it was about 25 milligrams at bedtime, no morning dose, and she did beautifully. She was able to stay in the home until she died. It was a good alternative. I came to the conclusion that no matter what the FDA said, for her, this was appropriate treatment. Someday we're going to have to make those decisions for our parents, maybe have somebody make them for us. I don't want to die as an agitated, aggressive elderly. If this has to happen, I wouldn't mind it happening to me. So you have to look at atypicals in the elderly. You may have to come in and read some of the literature. Here's a little bit of it for you. One from Drugs and Aging this year, one from American Journal of Psychiatry last year. and they looked at these FDA requirements, and basically they were not as bad as the FDA made it out to be. So here's one area where I really disagree with the FDA. I won't talk about cannabis right now. I have some disagreements there also. Well, what about these drugs in the pregnant female? The FDA in 2011 updated some of the safety labeling and basically said newborns whose mother had taken the drug in the 3rd trimester had some potential risks for extrapyramidal signs and withdrawal from these drugs. This was not intended to stop the use of these drugs in the pregnant female. At this point in time, there's no reported teratogenic effects of these drugs. If you find some papers that say there are, please feel free to send me those references. I would use caution. I'd use my head, but so far there are no contraindications. So in the bipolar female, you now have an option of either Lamictal from the anticonvulsant side or perhaps an atypical antipsychotic. The use has gone way up, but we have not yet seen teratogenic problems. Here's some 2013 references for you. I think doing your own PubMed search and just typing in atypical antipsychotic and pregnancy, you can pull up all the relevant literature. The nice thing about PubMed, besides the fact you get the abstract, is that you can, on many cases, get the full article and read and make your own decisions. This is another pregnancy outcome study from 2013 by Haberman, and their findings did not reveal a major teratogenic risk, making these drugs a treatment option for the treatment of bipolar disorder during pregnancy. If they're exposed in the last week of pregnancy, they're taking them right up to the time of delivery. Maybe delivery should be planned in facilities that have a neonatal ICU rather than perhaps having a home delivery in such an infant. This was another paper, 2013, 76 infants exposed to atypical antipsychotics and 78 controls. At 2 months of age, there was some slowing of cognitive, motor, and social skills. By 12 months, all of these had resolved. The birth weights were slightly lower, although these quickly resolved. Well, what are our first-generation agents? Well, these were the phenothiazines and Haldol. They were called major tranquilizers. These atypicals are not minor tranquilizers. When those terms major and minor tranquilizers were developed, the minor tranquilizers applied to the benzodiazepines and related drugs. Perhaps another time we'll have a talk on the so-called minor tranquilizers, the benzodiazepines. I've already stated that they necessarily cause Parkinsonian side effects. Because of that, we really didn't use them off-label. The risk of the side effects was too great for clinical use, and one of the only uses was control of nausea and vomiting, perhaps during pregnancy, and it did help there. And these were drugs of choice, actually, until about 1997, and that extended from 1955 when they first came on the market. Well, here's a laundry list for you of our new generation antipsychotics. Started with Moban in the 70s. Drug was never used much. Also Loxapine, that was not used much. Pimozide was not really used in this country. That was in '96. The first real widely used one was Clozaril in 1990. And we'll talk about that in a second. It had to be used under very, very carefully controlled situations, and it still is today. This was followed by Risperidone in 94, Zyprexa in 96, Seroquel in 99, Geodon in 2001, went off the market briefly, came back in the market, I believe, in 2002. Abilify in 2003, Paliperidone as Invega in 2006, Sustenna in 2009, then followed by Fanapt, Saffris, and the last one that came in the market was Latuda in 2011. So let's take a quick look at each of these drugs. And instead of, I'm going to here not include the first three. Those are discussed in the textbook. Clozaril was one of the first to really separate antipsychotic efficacy from extrapyramidal side effects. It brought a new era to schizophrenia treatment, basically saw awakenings. It's not the Robin Williams awakenings, which I believe was L-DOPA in Parkinsonism. This awakening essentially was from the fog of the side effects. I would love to see a movie called Awakenings 2, which would be the Clozaril story. The problem with this drug is it caused agranulocytosis, or it could wipe out your white blood cells. It was reversible on discontinuation if you caught it, but you have to draw blood and you have to do white blood cell counts. Originally, this drug was used only in patients who were institutionalized, then became used in patients who would be in a closely monitored clinical situation. The main side effects were fairly extreme sedation. They were really dopey, and incredible weight gain. It was difficult to treat this weight gain. There have been many, many papers out on it, included limiting access to food as perhaps the most effective. If you were incarcerated, for example, and were only given food trays, you could control their weight. The problem was they would do anything to barter for food. It was the worst of the antipsychotics. The next drug that came out was Risperidone, and this drug, Risperidone, is metabolized to an active drug called 9-hydroxyrisperidone with a half-life of about 23 hours. So the drug could be given once a day. Some of its side effects were headache, agitation, anxiety, insomnia, and extrapyramidal symptoms at high doses. It became a first-line drug for treating bipolar disorder and for some of the off-label uses. It was the first drug really FDA approved for the treatment of autism and pervasive developmental disorders in children and adults, and for the treatment of aggression in conduct disorder. It came out in an injectable form called Risperidone Consta, which was an every 2-week injection. The total 2-week dose was in a slow-release injection. Unfortunately, the manufacturer charged about $500 per dose, or $1,000 a month. And we'll revisit that issue later. The problem with Risperidone, or one of the major problems, is that the patent ran out. The drug had its 16-year run. So what's this poor drug company going to do? Well, they looked at this slide, not really, but basically, and saw this active intermediate. And it was pretty easy to find out whether anybody patented this active intermediate. Nobody had, so they patented that drug, and they marketed that drug as Paliperidone under the trade name Invega. And that became FDA approved. They called it a new molecular identity, or entity, and got a new 17-year patent life. And all this drug was the active metabolite of Risperidone, basically intended to keep the price of Risperidone high, but you do better in using a generic Risperidone. I understood the reps were running around with a mason jar with a big capsule inside, and says the beauty of this thing is it's got this Oros formulation. Well, the Oros is the capsule in which Adderall was marketed. It's a simple capsule, porous capsule. It had a coating of drug on the outside, and then the drug was in a gel on the inside. It's a marketing thing more than anything else. It already has a half-life of 23 hours. You really don't need to extend it any further. So it was strictly a marketing thing for the drug company. So obviously, I don't promote that. I think you're better off using inexpensive risperidone. Well, in 2009, Paliperidone came out as an injectable. Its claim to fame on this injectable was that it was a once a month, where Risperidone Costa was every 2 weeks. Well, the problem with this is since you only give it once a month, they doubled the price and they charged $1,000 a month for this, basically to rip off the patients. I said earlier that risperidone is probably drug of choice for the treatment of autism. Problems with it would be weight gain, glucose intolerance, and you have to monitor lipid levels in these children. You need to follow prolactin levels also, because like the phenothiazines, these drugs could increase prolactin levels and you can see breast enlargement. You have to monitor glucose levels and body weight. The drug is quite effective. One of the first papers was this one by Malone way back in 2002, even though it was not approved, I believe, until about 2006 or 2007. Risperidone will cut the autism behavioral scores about in half over a 12-week period, and that's the lower line here. And so the drug has demonstrable effects, and it's widely used for the treatment of autistic behaviors in children. Now, in 2007, it was FDA approved, and we have to look at some of the words here. It was for the symptomatic treatment of irritability. It reduces aggression, deliberate self-injury, and temper tantrums. It improves the scores of certain behavioral symptoms, namely this aggression, deliberate self-injury, and temper tantrums. It doesn't cure autism, it just controls some of the behaviors. So likely any atypical antipsychotic will look similarly, and since risperidone became widely accepted, interest today is now looking at Abilify. I think we come to that in a few minutes. Abilify as perhaps having less weight gain, less sedation, and less propensity to extrapyramidal signs, as well as weight gain and metabolic abnormalities. I have not seen head-to-head comparisons of risperidone and Abilify, but we'll look at the Abilify literature in a few minutes. A couple new ideas. It can reduce aggression, depression, and increase energy in patients with borderline personality disorder. Remember how we saw that with Topamax the other day? With Topamax being used to treat borderline personality disorder. Risperidone can do the same thing. We've already talked about the Risperidone Consta. The next atypical out was Zyprexa, and this was like Clozaril structurally, but it's devoid of the white blood cell loss. And indeed, there was one paper that demonstrated that Zyprexa metabolism could lead to a toxic intermediate that destroyed the white cells. Zyprexa does not do that. There's been tremendous weight gain, some sedation, and metabolic abnormalities such as early onset of diabetes. But it became quite widely used, and it's part of blanking on the trade name. Try lecturing for an hour, and you find occasionally you blank. This was a study 12 years ago, an old study, on weight gain with Zyprexa and Risperidone in adolescents. This study was on 50 hospitalized adolescents over a 12-week period. The Haldol patients did not change weight. The Zyprexa-treated patients gained about 1% of body weight per week, and it was still climbing at the end of the 12 weeks. Risperidone patients gained about half percent of body weight per week, and that was still climbing. This paper concluded that Zyprexa and Risperidone were associated with extreme weight gain in adolescents, much higher than that reported in adults. Can you imagine having a teenager, somebody around age 18 or so, sending them off to their first year at college, and they eat twice a day at a cafeteria where you have unlimited access to food. They call it the freshman 20. Here I would call it the freshman 50. They will just gain a tremendous amount of weight if they're associated, or if they're exposed to unlimited food. There's a table from the textbook on weight gain and second-generation antidepressants. And this is the percent of patients gaining weight. Clozaril, 54%, Zyprexa, 30%, Abilify, 19%, and all the way down to Geodon at 7%. The actual numbers in clinical practice may well be higher than these numbers. So if you have a patient with anorexia, and if they want to gain weight, Zyprexa will certainly do it. In a 6-week study in 17 patients, there was some reduction in depression, reductions in anxiety. It reduced some of the symptoms of the disorder, and they got significant increases in body weight, as you would expect. This will only work in patients who want to gain weight. Zyprexa has been used in bipolar. In autism, it's effective, usually not used today because of Risperidone, and it's been used in agitation and aggression. There are some injectables. There's a Zyprexa intramuscular. It's immediate acting and of short duration, used in the treatment of severe agitation with bipolar mania and schizophrenia. It was shown to be actually better than either intramuscular Haldol or Ativan, which are widely used in ERs. Zyprexa works very well. There's a once-a-month injection that came out in 2009 called Zyprexa Relprev. I have not seen this one used because you have to register with Lilly's patient care program, similar to the original Clozaril program, and this is because of post-injection delirium. So I personally have not seen this used. The next atypical that came out was Seroquel. This was related to Clozaril, initially claimed to have no weight gain. Whenever I lecture that, I hear a lot of snickers in the audience. Maybe that's opening Snickers bars, but attendees will say they've had patients who have had tremendous weight gain problems. The claim to fame on this thing, on Seroquel, is it has beneficial effects in cognitive functioning. I think that's important. These people seem to do intellectually and cognitively better on Seroquel than on drugs like Clozaril. This is an old paper from 2002. I leave it in here because this is a wide clinical use now. The drug is very, very effective in patients with resistant obsessive-compulsive disorder. Most of these patients have been on SSRIs or similar drugs, have not improved, and adding Seroquel, their Yale-Brown obsessive-compulsive scores can fall by about half. There was a little bit of weight gain, claimed not to differ from placebo. I today would question that. I think there is more weight gain. But the drug is a powerful anxiolytic drug and can be used in a wide variety of anxiety situations. Here's a paper on using Seroquel in resistant depression and anxiety. And this was a combination of Seroquel and Lamictal, effective in treatment-resistant bipolar depression. And it worked very well, very anxiolytic. It reduces psychosis in individuals with Parkinsonism. It did not aggravate the Parkinsonism. Was effective in schizoaffective disorder. It potentiates the efficacy of SSRIs in the treatment of OCD. And the drug is useful in bipolar disorder. The last one, to me, is most interesting. Effective in severe agitation, aggression, and impulsivity. Very, very effective there. And in parentheses, it says, even in criminals with antisocial personality disorders. I was lecturing in one town in the southeast. I won't mention the town. And there were two people, young people there from the criminal justice system, and they blurted out, quote, "We hate Seroquel," unquote. It really took me back, and I asked why. And I said, "Why do you hate Seroquel?" "They sleep all day." Yes, the drug can be sedating, but it calmed them to the point where they can get some sleep. Imagine what happens if you're boxed up in a locked cell, perhaps with somebody who doesn't like you. Extreme anxiety. And indeed, many of the jails have actually banned Seroquel because it works. To me, I think it should be in the vending machines, perhaps free. That these people with anti-personality disorders, with confinement, anxiety, things like this, they do extremely well with a drug like Seroquel. There's a study of Seroquel in adolescent mania, 28-day study in 50 adolescents, and it had faster reduction of symptoms and greater symptom reduction overall compared with valproic acid, which is Depakote. And there was a 60% remission in the Seroquel group versus a 28% remission in the Depakote group. Drug is extremely good in that situation. Geodon then came out next, and basically it's an effective atypical. The claim to fame is there's very little weight gain, and that's true. The drug is a serotonin 1 agonist like Buspar, and it inhibits reuptake of serotonin and norepinephrine like the tricyclic antidepressants. Therefore, mechanistically and clinically, the drug is antidepressant. It only had one major problem, and that was QT prolongation. When the drug first came out, a few people died, was taken off the market, and then came back on with enough notice about QT prolongation. This is a couple slides from the textbook, and it's looking at the EKG. And the EKG, if you palpate in your neck, you can feel the kaboom, and that's the QRS. And basically you get a depolarization, followed by in the atria, followed by propagation of the impulse over the ventricles, and you get this big QRS spike, followed by repolarization or resetting of the electrical activity of the heart. The QT interval is from the start of the Q, depolarization of the ventricles, to the end of repolarization. And that time is usually somewhere around 250 to 350 or so milliseconds. If your heart's beating at 60 times a minute, the whole cardiac cycle would be 1,000 milliseconds, once per second. If you get out and exercise, which I've always been taught is dangerous, avoid exercise at all costs, and let's say you get your heart rate up to 120. Now the whole electrical cycle of the heart is 500 milliseconds, of which the QT interval probably is around 400 milliseconds. If, this is the depolarization and the repolarization. This is heart rate, basically just beats on the EKG. And if the second pulse starts before the heart's been repolarized, you get what's called a Torsades-DuPont arrhythmia, which is usually fatal, can sometimes be stopped with a chest thump. When you see an young athlete who's running up and down the soccer field, drop dead in the field, that's usually from a Torsades-DuPont arrhythmia. Not the only cause, but it's one of the major ones. I had a psychologist at one of my seminars whose son had dropped dead in front of her in the soccer field. Horrible tragedy for the family, hard to comprehend. They later looked at QT intervals in all of these all the members of the family, and they had a congenitally short QT interval and were all at risk of this. This was a study by Blair a while ago, almost 10 years ago now. Looked at 20 subjects with an average age of 13 years, and these were on Geodon, and the average QT prolongation was 26 milliseconds. One reached 114, and 3 of these 20 youngsters reached a 450 millisecond threshold. Can be significant. Some children will be at risk, and it's now been advised that children, if you're going to be on Geodon, should have EKGs before treatment and also during treatment. It can happen in people not on Geodon, but if they were, you certainly know that the drug's going to be blamed. Several of our hospitals here in Portland now have a free clinics for children and adolescents where you can stop in, usually it's in the emergency room, you can get an EKG and they guarantee to get you out of there in 30 minutes, and this is to screen for QT intervals. And there are persons that are at risk, and they need to be monitored before they can go into competitive athletics. There is an IM Geodon, and this was the first atypical approved for intramuscular use back in 2003. Now, Abilify is the first one that's different from this dopamine 2 blockade, serotonin 2 blockade. This drug is a partial dopamine agonist at low doses. It's also a serotonin 1 agonist and a serotonin 2 antagonist. So at low doses, this drug is mechanistically antidepressant. As you push the dose higher, you can get dopamine 2 blockade, so the drug is actually biphasic in action, and you get an anti-schizophrenic effect. But at low doses, you get dopaminergic activation, and at higher doses, you get dopaminergic inhibition. The drug is mechanistically and clinically antidepressant. It's effective in bipolar mania. For some reason, less so in bipolar depression. It's been used in autism, conduct disorder, bipolar disorder, etc. It is, if you watch television advertisements, and I always urge you to not watch television, but if in the back of your mind you hear an ad for a psychiatric use of drugs, listen to it and see what they're talking about. There's many ads on TV now for Abilify as an augmenter of clinical antidepressants because it has that FDA approval. So it may be more, combined with an SSRI, it may be more effective than a mood stabilizer such as Lamictal. paper by Nickel on Abilify and borderline scores, obsession compulsive scores, reduced depression, anxiety, hostility, paranoid thinking, socially desirable anger control, and self-injury was reduced. So the drug has efficacy in patients with anger and borderline diagnoses. Another paper by Lieb in 2010, and it was a Cochrane review of the pharmacotherapy for BPD. And it basically said that some of the mood stabilizers are effective, as are the atypicals such as Abilify, Zyprexa, and Asenapine. I believe this can be downloaded free, if I remember right, off PubMed Central, and you're welcome to take a look at it. In adults approved for schizophrenia and bipolar mania, among resistant anxiety disorders, and also for resistant depression and autism. We'll look at a little bit of the autism literature, and it does reduce conduct disorder, aggressive behaviors in conduct disorder. This is my conservative dosing. I think the lower in dose you stay with Abilify, the better off you are. If you add another drug, such as Depakote or an SSRI, they will inhibit the enzyme that metabolizes Abilify, the hepatic 3A4 and 2D6, and therefore you have the dose on patients who are on SSRIs or Depakote. And I put in this slide, except citalopram and escitalopram, since those two SSRIs do not inhibit hepatic drug metabolism. A paper this week, or not this week, this came out, I believe, in February. This is in manic episodes in adolescents with bipolar 1, and they looked at efficacy at 10 milligrams for 12 weeks. And if you push the dose, it's not necessary. If you go to PubMed and type in Aripiprazole and autism, you can pull up a variety of papers that usually begin with this one by Stigler in 2009, who first showed that an average dose in patients from 5 to 17 years, average 8 years old, mean dose of Abilify of about 7 or 8 milligrams per day. About 90% had very much improved durability scores, including aggression, self-injury, and tantrums. This was an open study. Marcus did a double-blind fixed-dose study, and as of the last that I searched the literature, there's no comparative studies of Abilify and Risperidone. Risperidone in autism is still the #1 drug. Abilify, they seem to be much more awake. I had one counselor tell me that on one of her students with autism that on Risperidone they basically slept all day, and when this youngster was switched to Abilify, there was much less sedation, and she was actually able to sit down and play a game with this person, something that she had never been able to do before. This is Harvard Review this year. I believe it was a January issue. And autism's incidence is about 1 in 88 children. And it said there's strong evidence for the efficacy of Risperidone and Abilify in severe irritability and aggression. There was minimal evidence for any efficacy of the anticonvulsants or lithium. The next drug that came out, and this was 2009, was Fanapt. This was actually an old drug that was bounced around from several manufacturers since the mid-90s. I personally don't see anything outstanding about Fanapt. or a reason for it to really be prescribed. Half-life is long, much like Risperidone. It blocks dopamine and serotonin receptors. It's kind of an old drug that was reintroduced for clinical use with no outstanding indications to my knowledge. Latuda came out late in 2010 for schizophrenia. It was fairly expensive. The drug is now FDA approved for treating bipolar depression, similar to Geodon, but no QT prolongation. Claimed to have fewer side effects. Of course, all new drugs make that claim. The rate of akathisias, the movement disorder, which is fairly high with Abilify. That's one of the major side effects of Abilify. The other side effect with Abilify, I forgot to mention it, is the feeling of bugs under the skin. But you get these akathisias also with Latuda. Once-a-day dosing, side effects aren't too bad. It's claimed to fame today is use in bipolar depression. It's as good as monotherapy. It's effective as monotherapy, and it may even be better in combination. There's a couple papers for you to read on it. This paper by McIntyre and CNS Spectrums is free for download. If you go on PubMed, type in McIntyre and bipolar depression, this will come up as free text, and you can print it out. And I believe they state that they talk FDA-approved drugs are the Zyprexa Prozac combination, Seroquel, and Lurasidone, and evidence also supports the use of lamotrigine. And you may, as time goes by, you may see more use of lamotrigine and Lurasidone in combination. Another drug that came out was Saffris. There's quite a market for these drugs. A lot of it is because of the off-label use. It's used sublingually. It's not absorbed if swallowed, so it's absorbed through the buccal membranes of the mouth. Mild to moderate efficacy. It's expensive. There's one paper out this year on the use of it in borderline personality disorder. Couple new drugs that are in clinical testing. I'm not going to go into them here. You can read those on your handout, or you can look up each of these drugs on PubMed, which is the way I would do it, and just see what the literature is saying about these drugs. And I think I finished right on time. It's been about 55 minutes. I will stick around online for questions. I have no hurry, so I'm able to stay here. I thank you all for attending.
Great. Thank you, Bob. That was great. So I'm going to go through the continuing education slide here really quickly, and then we'll get back to questions. So we are at an hour.
Yeah, but you took the first couple minutes of it.
I'll give them back here in a minute.
Okay, good.
Okay, so thank you all again for joining. I just wanted to let you know this does qualify for continuing education credits, and here is the code that you will need when you're taking the questionnaire. So you will receive the questionnaire if you attended on Wednesday this afternoon, and then this one, the questionnaire along with the slides, and the recording of this will be sent to you on Monday. You can also see the recordings for the entire week. So Monday's presentation along with Wednesday and Friday will be posted at Faculty Lounge. There's a lot of wonderful resources there, so I encourage you to go there to view the recordings as well as the other resources that we have posted there too. So they will be emailed to you and available at this website as well. And with that, we will get back to questions.
I might mention here, I've just a little bit talked with Elizabeth about doing more of these lectures, perhaps in other chapters of the book, that you can either show to the students or view yourself to aid your teaching. I don't know if Joe or Claire joined us, but they are certainly welcome to jump in here and see if they would like to do a few of these also. The textbook was mine for many years, and now it's Joe and Claire are taking the book over, and they will be working on the 14th edition.
Great. Yeah, and I've already received feedback that that would be helpful, Bob. So we'll work together on perhaps scheduling some more in the future for students as well as instructors.
All right. Questions out there?
I'm looking for questions. I don't see any typed in. Does anyone have a question they would like to ask over the phone? If you do, go ahead and click on that little icon that says, that doesn't say, but rather it has a little hand, and you can raise your hand and it'll take you off of mute, or you can type in the chat box.
Now, since I'm so passionate about it, while I'm waiting for someone to step forth, I pulled up the PubMed page again, and it's worth reiterating. Let's just type in Lurasidone. Hopefully I spelled it correctly. I did. And these are all the different things you can search for. Any paper that has Lurasidone in it, the use in bipolar disorder. How about bipolar depression? This is kind of one that we talked about. And it's searching for that. There's 30 papers. Interestingly, paper number 1 has a review of the pharmacology of lithium. Somebody asked me about that the other day. Here's a study for schizophrenia, I believe, paper on bipolar depression, so on and so forth. And you just click on a couple boxes. I'll click on
Bob, if you could click on share your desktop again, we're not seeing your screen just yet.
Okay, share my desktop.
Thank you.
Did that do it?
That did it.
Okay, good. As I said, I'm not very computer savvy. I searched Lurasidone and bipolar depression. 30 papers that have those names in the title of the abstract. And I just clicked on a couple of them that the titles looked interesting. I will click on abstract, click on apply, and there are the abstracts, and you can just click and read about it. I don't know if there's I don't know if there's any available full text. I'm going to scroll down and see if there are. Here's a paper on neuropsychiatric diseases and treatment. Lurasidone is a potential therapy for bipolar. Here's a free text available. I remember the days, and I used to have to spend days in the library looking for these things. And where does it say the full article on this one? I don't see where they put it. Somewhere on here there's a click to get the full article. Open access. Don't know. Anyway, sorry. Didn't work that time. Doesn't work all the time.
We do have a couple questions coming in. Anne, you're off of mute if you want to go ahead and ask your question.
Okay. I'm new to this. This is my first webinar I've attended, so thank you for setting it up. I use an intro.
Attending.
Yeah, I teach psychology at a community college in Michigan, but I've been long interested in a lot of these things, and now I've been teaching a couple courses in drugs and neuropsychology of addiction. I use a lot of help from pharmacology graduate students and postdocs from University of Michigan to help me with the harder material. But I think I'm going to ask something and kind of be a little bit direct. I read an article, I think it was from NIH a couple of years ago, that was very, very critical of all antipsychotics. And it was written by, very esteemed people. It was a review of hundreds and hundreds and hundreds of publications. I think it's the contrast between the effectiveness of a drug versus its efficacy in the real world, the number of people that don't stay on it, just that the entire enthusiasm, not just for the first generation, but for all the generations, has been oversold, and that it could be largely due to the money-making of the pharmacology industry.
Yeah, of the industry. There's certainly a degree of that, no doubt. And the problem here, I think, is that industry and much of what you hear is strictly about the drug. Can you come in and just give somebody a pill and expect this thing to work incredibly well? That's absolutely not true. On Monday, when we talked about antidepressants, the efficacy is very poor. Here we're looking at a class of drugs that could have just run amok The thing that I like to bring out is that these drugs should always be used judiciously, always be used with psychological therapies. I remember after I gave one of these lectures, a psychologist came up to me and kind of his head hung down low and he was kind of sheepish, and he said, "Dr. Julien, are we antiquated?" And the question is absolutely no. What I did here for you is I went to my website, drjulien.com, and I would ask you to, here's articles by me, and one of these is, I showed it the other day, and it's called Psychopharm Training in Clinical Psychology. I was asked to write this review. I urge you to take a look at this paper.
Okay.
There is a list of a dozen or so things that this is how we should work together. All psychologists should be trained and competent to do the following. Do all of this. Do the testing. I'm seeing even neuropsychologists now who write up their whole report based just on a patient interview. Not doing the testing. I mean, your claim to fame is testing.
Right.
Do the family history. See if they need a medical eval. Get the plan of therapy. Focus on the risks and the benefits of the treatment options. Monitor for the side effects. Do the discontinuation planning. Basically, come in and be a member of the healthcare team.
Right.
This has to be done.
Yeah. I'm very heartened by what you're saying. So would you say, some of the critique of the antidepressant literature is that there was a publication bias, and then also that even among the papers that were more critical, that the placebo effect was pretty close to as strong as the antidepressant effect. How do you,
well, in case of antidepressants, placebo
yes,
in case, is good.
Yes. Okay. So with this one, when you most of the data that you just cited, there weren't like numbers like, would you say 40% of schizophrenics benefit with once you find the right combination, or would you say 60%, or what would be the?
A patient with schizophrenia, the drug is essential. You just have to use it. But there's other things in working with these clients that you should be doing. The doc's not going to do it.
Right.
He's told 12 hours a day to prescribe meds. And unfortunately, physicians and psychologists, psychiatrists are sucked into it too. They've just become medicine managers.
Right.
They're not doing.
I don't know why that is either, because they go through a lot of training that encompasses. My niece just finished psychiatry training, and it wasn't just about managing medicine. She's working with clients in therapy all the time.
Yeah.
So I don't know why they just.
Well, basically, it's money. You can have short visits, you can manage their meds, and you get paid for a patient visit. You're not paid well for an hour-long therapy session.
Okay.
We could talk about this for hours. And
okay. All right. Good. All right.
But you might start with this paper, and
I will.
I think psychologists need to do what they're supposed to do, which is come in and manage the patient.
Right.
Because the doc's not going to do it.
Okay, thank you very much.
So we need a long talk on that.
We do have one other question here. On Monday, you mentioned that one of the effects of one of the drugs was neurogenesis. Someone would like you to expand on that if possible.
Oh, sure. That doesn't apply to today's lecture, but there's a huge literature on antidepressants and you can see what I just did. Whoop. Oh, there's 608 papers where that's mentioned. And we want to find and review. This is how you narrow those numbers down. Type in and review. 210. And if you look at these, you will pull up papers that talk about how antidepressants can help heal injured brains, injured neurons, especially in the hippocampus. One of the lead authors who writes fairly easily is Duman. I'm going to see if I can pull his up. 22 papers. And there's all sorts of these. Here's even one on ketamine. You can download it free. And you can study how, well, here's one right here. Regulation of neurogenesis and gliogenesis by stress and antidepressant treatments. And you can just look at his review papers. I think some of them are free because I've downloaded some of them. This number 20, old paper, this is the first one, regulation of adult neurogenesis by antidepressant treatments. These drugs seem to heal damaged neurons. In depression, the brain size actually shrinks by about 10%, and you can restore that with antidepressant therapy. And it's discussed in the textbook quite extensively. Many of these references are there, and I think what you will find is that you can learn a lot from it. Molecular aspects of antidepressant therapy, effects on signal transduction, gene expression, and neuronal plasticity. A very important area to learn in psychology. I don't believe it's really taught as a mechanism of depression, but students should be taught this. It's a great area for them to do literature research and write a paper. It's an area that you can talk about for days about brain mechanisms and how mechanisms are affected in disease. In my forensic practice, I'm seeing lots of persistent brain defects after the use of ecstasy, methamphetamine, and cocaine. And these all have to do with alterations of the blood-brain barrier and nerve damage because of junk that gets in the brain. Those things, I think, are vital and need to be taught to students. But basically, the easiest way to put it, as you look at the literature, is that it just heals damaged neurons. And the mechanisms, I think Joe and Claire wrote that section. Claire went into it quite deeply in the textbook. So good luck with it. It's a challenging area to study, and it's absolutely vital for students in psychology to understand this.
Okay, and I think that's all the questions we have for now, unless anyone has any other ones where they'd like to be taken off of mute.
I thank you all for attending, and hopefully if we do more of these, hopefully I'm sure you'll be notified by the publisher.
Absolutely, yes. Thank you again, Bob. We really appreciate it, and we thank all the attendees on the phone as well. This is great.
My privilege, and thank you for attending.
Thank you. Bye, everyone.